So we will continue the lecture. Woodpasture syndrome is characterized by Woodpasture syndrome is characterized by acute renal failures due to RPGN and pulmonary hemorrhage. The condition is more common in males, specifically in third decade of life. The disease results from damage to the glomeruli by anti-GBM antibodies. These anti-GBM antibodies cross-react with the alveolar basement membrane and hence produce renal as well as pulmonary lesions. So, sorry for the interruption. The disease results from damage to the glomeruli by anti-GBM antibodies, which cross-react with alveolar basement membrane and hence produce renal as well as pulmonary lesions. The evidence in support are the characteristic linear deposits of anti-GBM antibodies consisting of IgG and complement along the glomerular basement membrane. Detection of circulating anti-GBM antibodies and induction of glomerular lesions with injection of anti-GBM antibodies experimentally in monkeys. Pulmonary lesions can be experimentally induced if the lungs are previously injured by viral or bacterial infections or if exposed to hydrocarbons. The Woodpasture antigen appears to be component of collagen type 4. Morphology of Woodpasture syndrome. Grossly, the kidneys are usually enlarged and pale with smooth outer surface. Large white kidney, known as large white kidney, cut surface shows pale cortex and congested medulla. On histological examination, this is the histological picture of RPGN showing the epithelial crescent, which is denoted by a arrow, and the capillaries, the normal capillary architecture of the glomeruli is collapsed, which is shown in the microscopic pictogram. Rapidly progressive glomerulonephritis, the echo picture. This is a light microscopy where we will see the glomeruli show focal necrosis, diffuse or focal endothelial proliferation, and mesangial proliferation. And the histologic picture is dominated by distinctive crescents showing in the pictogram. Concentric glomerulonephritis, collapsed glomerular and essential masses of proliferating parietal epithelial cells. When we talk about tubules, the tubular epithelial cells may show hyaline droplets. Tubular lumina may contain casts, red blood cells, and film. Interstitium, the interstitium is edematous and may show early fibrosis. The inflammatory cells, visually lymphocytes and plasma cells. These are commonly distributed in interstitial tissue. Vessels, changes in vessels, the histological features of vessels. Arteries and arterioles may show no change at all, but cases associated with hypertension usually show severe vascular changes. Another entity, membranous nephropathy. It is characterized by Diffuse thickening of glomerular capillary wall due to the accumulation of deposits containing immunoglobulin along the subepithelial side of the basement membrane. The various causes of membranous nephropathy are SLE, that is systemic lupus erythematosus, malignancy like colon carcinoma, lung carcinoma, and malignant melanoma. Drugs, specifically penicillamine, captopril, and gold. Infections responsible for membranous nephropathy are hepatitis B, hepatitis C, and syphilis. Other important causes are diabetes mellitus and thyroiditis. Primarily, formerly idiopathic, membranous nephropathy is an autoimmune disease caused in most cases by antibodies formed against renal autoantigen. A major recent advance came from the identification of M-type phospholipase A2 receptor, very important, that is PLA2R, as the antigen that underlies 60% to 70% of human membranous nephropathy. Autoantibody binding to PLA2R or M-type phospholipase A2 receptor, a membrane protein at the basal surface of the glomerular epithelial cells, is followed by complement activation and then shedding of immune aggregates from the cell surface that form characteristic deposits of immune complexes along the subepithelial aspect of the basement. Morphology of MPGA, again classified under glomeruli. The characteristic finding is diffuse thickening. The characteristic finding is diffuse thickening of the glomerular capillary walls, with all the glomeruli being affected more or less uniformly. As the disease progresses, the deposits are incorporated into enormously thickened basement membrane, producing duplication of glomerular basement membrane, which is actually formation of a new basement membrane. These basement membrane changes are best appreciated by silver impregnation stains, which imparts black color to the basement membrane, or by periodic acid shift stain, that is PAS stain, which impart pink color to the basement membrane, and there is no cellular proliferation in the glomerular tufts. Electron microscopy, it is very specific, shows characteristic electron dense deposits in subepithelial depression. The basement membrane material protrudes between the deposits as spikes. Immunofluorescence microscopy reveals granular deposits of immune complexes which consist of IgG associated complement C3. In secondary cases of membranous glomerulonephritis, the relevant antigen such as hepatitis B or a tumor antigen may be seen. Next entity, minimal change disease, suggestive in name itself, minimal changes seen in the glomeruli. This relatively benign disorder is characterized by diffuse effacement of food processes of visceral epithelial cells, which are also known as podocytes. So in crux, we can say that it is a diffuse effacement of the podocyte, detectable only by electron microscopy. When seen under light microscopy, when examined under light microscopy, the glomeruli appear perfectly normal. Hence the name minimal change disease. It is the most frequent cause of nephrotic syndrome in children. So we can say that the most common cause of nephrotic syndrome in children is minimal change disease. But it is less common in adults. The peak incidence is between 2 and 6 years of age. So as I told you, the peak incidence is between 2 and 6 years of age. Nephrotic syndrome in minimal change disease in children is characterized by selective proteinuria containing mainly albumin and minimal amounts of high molecular weight protein such as alpha-2 macroglobulin. The basis for selective proteinuria appears to be as under number 1, reduction of normal negative charge on glomerular basement membrane due to loss of heparan sulfate proteoglycan from the glomerular basement membrane. Change in the shape of epithelial cells producing food processes flattening due to reduction of sialoglycoprotein cell. Morphologically, the glomeruli are absolutely normal, as I told you on the light microscopy. Tubules, there is presence of fine lipid vacuolation and hyaline droplets in the cells of proximal convoluted tubules. The principal lesion is in the visceral epithelial cells, which show a uniform and diffuse effacement of food processes, which is evident on electron microscopy. I told you earlier. By electron microscopy, the most characteristic feature of the disease is identified, which is diffuse flattening of food processes, all the visceral epithelial cells, that is podocytes only, and hence the name food process disease or podocytopathy. Next entity is focal segmental glomerulosclerosis. Primary FSGS is the most common cause of nephrotic syndrome in adults. This lesion is characterized by sclerosis of some but not all glomeruli, thus the term focal. And in the affected glomeruli, not the full glomeruli is affected. Only a portion of the capillary tuft is involved, hence the name segmental. So, in crux, this is the basis of the term which is formed focal segmental glomerular sclerosis. FSGS is frequently manifest clinically by the acute or subacute onset of nephrotic syndrome or non-nephrotic proteinuria. Hypertension, microscopic hematuria, and some degree of azotemia. We have discussed azotemia previously in previous slides, are commonly present when the disease is first clinically recognized. It has following types. As a primary disease known as idiopathic local segmental glomerulosclerosis in association with other known conditions such as HIV infection, it is known as HIV associated nephropathy, heroin addiction known as heroin nephropathy, ulcer disease, and morbid obesity. As a secondary event, reflecting scarring of previously active necrotizing lesions in case of focal glomerulonephritis. Example is IgA nephropathy. As a component of the adaptive response to loss of renal tissue, that is renal ablation, whether from congenital anomalies, example unilateral renal agenesis or renal dysplasia, or acquired causes, example reflux nephropathy, or in advanced stages of other renal disorders such as hypertensive nephropathy. Okay? In uncommon inherited forms of nephrotic syndrome where the disease may be caused by mutations in genes that encode proteins localized to the slit diaphragm. Example, Tyrosine, alpha-actinin 4, and TRPC6. The TRPC6 is for transient receptor potential calcium channel 6. Pathogenesis of FSGS. The characteristic degeneration and focal disruption of visceral epithelial cells with effacement of food process resemble the diffuse epithelial cell change, typical of minimal change disease and other podocytopathies. This epithelial damage is the ultrastructural hallmark of FSGS. Multiple different mechanisms can cause such epithelial damage, including circulating factors and genetically determined defects affecting components of the slit diaphragm complex. Recently, genetic defects are identified which leads to FSGs. This affects the integrity of normal glomerular filtration barrier, like mutation in NPHS1 gene and NPHS2 gene that encodes for proteins, nephrin and podocyte, respectively. Both of these proteins are important for maintaining structural integrity of podocytes. Apart from that mutation in alpha-actinin 4 and TRCP6 gene that helps in maintaining filtration integrity also leads to FSGS. Morphology. Light microscopy show focal and segmental involvement of glomeruli, collapse of basement membrane, hyanosis, and sclerosis. Unaffected glomeruli show increased mesangial cellularity. By electron microscopy, diffuse loss of food processes as seen in the minimal change disease is evident. But in addition, there are electron dense deposits in the region of hyalinosis and sclerosis, which are believed to be immune complexes. By immunofluorescence microscopy, the deposits in the lesions are shown to contain IgM and Cg. Next is MPGN, that is a membranoproliferative glomerulonephritis. It is another important cause of nephrotic syndrome in children and young adults, which are characterized by two histologic features. Number one, increased in cellularity of the mesangium associated with increased globulation of the tongue, irregular thickening of the capillary wall. Type 1 or classic form is an example of immune complex disease, comprises more than 70% of the cases. It is characterized by immune deposits in the subendothelial position. Type 2 or dense deposit disease is the example of alternate pathway disease and constitutes about 30% of the cases. The capillary wall thickening is due to deposition of electron dense material in the laminar densa of the glomerular basement membrane. Type 2 MPGN, it is an autoimmune entity, it is an autoimmune disease in which patients have IgG autoantibody, term C3 nephritic factor. Morphology. Glomeruli show highly characteristic changes. They are enlarged with accentuated lobular pattern. The enlargement is due to variable degree of mesenchymal proliferation increase in the mesenteric surface. The GBM is considerably thickened, which with silver stains shows two basement membranes with a clear zone between them. This is commonly referred to as double contour splitting or tram track appearance. This is a characteristic feature. Electron and immunofluorescence microscope. Type 1. It shows electron dense deposits in subendothelial location, confirming to immune complex character of the disease. These deposits reveal positive fluorescence for C3 and slightly fainter staining for immunoglobulin G. Type 2. The hallmark of type 2 MPGN is the presence of dense amorphous deposits within the lamina densa of the glomerular basement membrane and in the mesentery. Immunofluorescence studies reveal the universal presence of C3 and properdin in the deposits, but the immunoglobulins are usually absent. Type 3. This rare form has electron dense deposits within the glomerular basement membrane as well as in the subendothelial and subepithelial regions of the GBM. Immunofluorescence studies show the presence of C3, IgG, and IgM. IgA nephropathy, also known as Berger disease. It is characterized by the presence of prominent deposits in the mesangial regions and recurrent hematuria. It is the most common type of glomerulonephritis worldwide. The disease can be suspected by light microscopic examination, but the diagnosis is solely made only by the detection of glomerular IgA deposition. Pathogenesis of IgA nephropathy. It involves abnormality in IgA production, that is immunoglobulin A production abnormal, and abnormal clearance of the IgA. Abnormality in glycosylation of the IgA, which may be hereditary or may be acquired. This leads to decreased clearance of the immunoglobulin A, which in turn get entrapped in the mesenteric. IgA containing immunocomplexes get entrapped in the mesenteric. Activation of mesangial cells, release of cytokines and growth factors, recruitment of inflammatory cells and activation of complement pathway, initiation of glomerular injury. On histologic examination, the lesions vary considerably. The glomeruli may be normal or may show mesangial widening and endocapillary proliferation. Mesengoproliferative glomerulonephritis. Segmental proliferation confined to some glomeruli. Focal proliferative glomerulonephritis. Rarely overt crescentic glomerulonephritis. The presence of leukocytes within glomerular capillaries is variable feature. The mesangial widening may be the result of cell proliferation, accumulation of matrix, immune deposits, or some combination of these abnormalities. Healing of the focal proliferative lesion may lead to secondary focal segmental sclerosis. The characteristic immunofluorescent picture is of mesangial deposition of immunoglobulin A. Diabetic nephropathy, very important. Renal involvement is an important complication of diabetes mellitus. End-stage kidney with renal failure accounts for deaths in more than 10% of all diabetics. Renal complications are more severe, develop early and more frequently in type 1 diabetes, 30 to 40% of the cases approximately, than in type 2 diabetes. Diabetic nephropathy encompasses 4 types of renal lesions in diabetic mellitus, namely diabetic glomerulosclerosis, vascular lesions, diabetic pyelonephritis, and tubular lesions. Pathogenesis of these lesions in diabetes mellitus is explained by the following sequential changes. First, there is hyperglycemia, then glomerular hypertension, then renal hyperperfusion, then deposition of proteins in the mesangium, then glomerulosclerosis, and then last, renal failure. Glomerulosclerosis in diabetes may take one of the 2 forms: diffuse lesions in the nodule. Diffuse glomerular lesions are the most common. There is involvement of all parts of glomeruli. The pathologic changes consist of thickening of the glomerular basement membrane and diffuse increase in mesangial matrix with mild proliferation of mesangial cells. Various exudative lesions such as capsular hyaline drops and fibrin caps may also be present. Capsular drop is an eosinophilic hyaline thickening of the parietal layer of Bowman's capsule, which bulges into the glomerular space. Fibrin cap is homogeneous, brightly eosinophilic material appearing on the wall of peripheral capillary of fibrin. Nodular lesions of diabetic glomerulosclerosis are also called as Klinefelter-Wilson lesions of intercapillary glomerulosclerosis. These lesions are specific for type 1 diabetes, that is juvenile onset diabetes, or islet cell antibody positive diabetes mellitus. The pathologic changes consist of one or more nodules in a few or many glomeruli. Nodule is an ovoid or spherical, laminated, highly acellular mass located within a lobule of the glomulus. The nodules are surrounded peripherally. The nodules are pass positive and contain lipid and fibrin. As the nodular lesions enlarge, they compress the glomerular capillaries and obliterate the glomerular tuft. As a result of glomerular and arteriolar involvement, Renal ischemia occurs, leading to tubular atrophy and interstitial fibrosis. Grossly, kidney appears small and compact. Alport syndrome, very important. It is relatively more common. Is an X-linked dominant disorder having mutation in the alpha 5 chain of type 4 collagen, which is located on X chromosome. It affects males more severely than females. The syndrome consists of sensory neural deafness, ophthalmic complications like lens dislocation, posterior cataracts, and corneal dystrophy, and is also associated with hereditary arthritis. The condition is slowly progressive, terminating in end-stage kidney disease. In the second or third decade of the life. The common presenting features are persistent or recurrent hematuria, accompanied by erythrocyte casts, proteinuria, and hypertension. On light microscopy, glomeruli have predominant involvement and show segmental proliferation of mesangial cells with increased mesangial matrix and occasional segmental sclerosis. Another prominent feature is the presence of lipid-laden foam cells in the interstitium. As the disease progresses, there is increasing glomerulosclerosis of tubular atrophy and interstitial fibrosis. Electron microscopy reveals characteristic basement membrane splitting or lamination in the affected parts of glomeruli. Immunofluorescence studies failed to show deposits of immunoglobulins or complement components. ATI is characterized by acute tubular necrosis injury. ATI is characterized by acute renal failure and often, but not invariably, morphologic evidence of tubular injury in the form of necrosis of tubular epithelial cells. Acute tubular injury is characterized by acute renal failure and often, but not invariably, morphologic evidence of tubular injury in the form of necrosis of tubular epithelial cells. Because necrosis is often not present, the term ATI is preferred by pathologists over the older name, that is acute tubular necrosis. It is the most common cause of acute tubular injury. Renal tubules are highly susceptible to injury by ischemia and toxic agents. Tubular damage in ischemic ATM is initiated by arteriolar vasoconstriction induced by renin-angiotensin system, while in toxic ATM by direct damage to tubules by the enzyme. Debris of the discriminated epithelium due to necrosis causes tubular obstruction and may block urinary outflow with consequent reduction of GFR and also produces cast milk. These events cause increased intratubular pressure, resulting in damage to tubular vessel. Due to increased intratubular pressure, there is tubular rupture. Damaged tubules is accompanied with leakage of fluid into the interstitium, causing interstitial edema. Leakage of tubular fluid into the interstitium increases interstitial pressure. Leaked fluid incites most inflammatory response. Increased interstitial pressure causes compression of tubules and blood vessels and setting up a vicious cycle of accentuated ischemia and necrosis. Ultimately, leads to reduced GFR and consequently organ ischemic ITM, ischemic intratubular necrosis, shock, post-traumatic, surgical burns, dehydration, obstetrical and septic type, crush injury, non-traumatic rhabdomyolysis induced by alcohol, comma, muscle disease or extreme muscular exertion, myoglobinuric necrosis, mismatched blood transfusion, black water fever, hemoglobinuric necrosis. Grossly, the kidneys are enlarged and swollen. In cut section, the cortex is often hidden and pale, while medulla is dark. Histologically, predominant changes are seen in the tubules, while glomeruli remain unaffected. The interstitium shows edema and mild chronic inflammatory cell infiltrate. Tubular changes are as follows: dilatation of the proximal and distal convoluted tubules, focal tubular necrosis at different points along the nephron, flattened epithelium, lining the tubules suggesting epithelial regeneration, eosinophilic hyaline cast or pigmented hemoglobin and myoglobin cast in the tubule. Disruption of the tubular basement membrane adjacent to the cast may occur, known as tubuloresis. Toxicity: general poisons such as mercury chloride, carbon tetrachloride, ethylene glycol, mushroom poison, and insecticides. Heavy metals, mercury, lead, arsenic, phosphorus, and gold. Drugs such as sulfonamides, certain antibiotics like gentamicin, cephalosporin, anesthetic agents, methoxyfluorine, barbiturates, salicylates. Radiographic contrast material. Morphology: grossly the kidneys are enlarged and swollen. On cut section, cortex is pale and swollen, while the medulla is slightly darker than normal. Histologically, the appearance varies according to the cause of toxic agent, but in general involves the segment of tubule diffusely. Unlike ischemic atia, where the involvement of nephron is focal, tubules show following features: epithelial cells of mainly proximal convoluted tubules are necrotic and desquamated into the tubular lumina. The desquamated cells may undergo dystrophic calcification. Tubular basement membrane is generally intact. The regenerating epithelium, which is flat and thin with few mitosis, may be seen lining the tubular basement. Tubular interstitial nephritis. This group of renal disease involves inflammatory injuries of the tubules and interstitium that are often insidious in onset and are principally manifest by azotemia, tubulointerstitial nephritis can be acute or chronic. Acute tubulointerstitial nephritis has a rapid clinical onset and is characterized histologically by interstitial edema, often accompanied by leukocytic infiltration of the interstitium as well as of the tubules and tubular injury. In chronic interstitial nephritis, there is infiltration with predominantly mononuclear leukocytes, prominent interstitial fibrosis, and widespread tubular effect. Tubulointerstitial disorders are distinguished clinically from the glomerular diseases by the following hallmarks. Number one, absence of nephritic or nephrotic syndrome. Number two, presence of defects in tubular function. The latter may be subtle and include impaired ability to concentrate urine, evidenced clinically by polyuria or nocturia, salt wasting, diminished ability to excrete acids, condition known as metabolic acidosis, and isolated defects in tubular reabsorption or secretion. Acute pyelonephritis and urinary tract infection. Pyelonephritis is one of the most common diseases of the kidney and is defined as inflammation affecting the tubules, interstitium, and renal pelvis. More than 85% of urinary tract infections are caused by the gram-negative bacilli. Data normal inhabitants of the intestinal tract. By far, the most common is Escherichia coli, followed by Proteus, Klebsiella, and Enterobacter species. There are two routes by which bacteria can reach the kidney. Number one, through the bloodstream, known as hematogenous infection. Number two, from the lower urinary tract, known as ascending infection. Ascending infection is the most common cause of clinical pyelonephritis. Normal human bladder and bladder urine are sterile. Therefore, a number of steps must occur for renal infection to occur, which are as follows. The first step is colonization of the distal urethra and introitus in case of female by coliform bacteria. This colonization is influenced by the degree of bacterial adherence to urethral mucosal epithelia, as discussed, in which involves adhesive molecules known as adhesins on the P fibril storage villi of bacteria that interacts with receptors on the surface of urethral cells. From the urethra to the bladder, organisms gain entrance during urethral catheterization or other instrumentation. Long-term catheterization is, in particular, carries high risk of infection. Morphology. The gross features are well developed cases of acute pyelonephritis, showing enlarged and swollen kidney that bulges on section. On cut surface shows small yellow-white abscesses with a hemorrhagic rim. These abscesses ranges from several millimeters across and are situated in the cortex. Microscopically, acute pyelonephritis is characterized by extensive acute inflammation comprising of neutrophils involving the intestine, causing destruction of the tubules. Generally, the glomeruli and renal blood vessels show considerable resistance to infection and hence are spared. The acute inflammation may be in the form of large number of neutrophils in the interstitial tissue bursting into tubules, or may form focal neutrophilic abscesses in the renal parenchyma.
And